Perfect. So welcome everybody. Good afternoon, buenas tardes, or morning still, buenos dias technically. My name is Octavio. I'm a health educator with the University of Arizona Cancer Center. So today we're here to talk about prostate cancer. Joining me today we have from NACA, Native Americans for Community Action, we have Kellen Pollen Yumtewa. Good morning, Kellen. How are you?
Good morning. Thank you for inviting me today. I'm excited to talk about the topic today.
Yes, absolutely. Thank you so much. So we had Kellen on one of our webinars earlier in the year, talking about the great work that they do over at NACA in Northern Arizona. So please check out that webinar. If you haven't, you can see all of the great work that they do up there and learn more about Kellen. So thank you so much for being with us here today, Kellen. So we're going to be discussing prostate cancer. September is Prostate Cancer Awareness Month, all month long. We're getting toward the end of the month, but nevertheless, we decided let's put this out there, really important to talk about. And thank you so much for joining me, Kellen. So what we're going to do is I have a quick little presentation that I set up. So Kellen, if you'll bear with me as I present that, just go over the facts, the basics. We're going to talk about things like prevention, screening, all that good stuff. And then we'll kind of debrief and talk about this stuff together.
Great.
Okay, perfect. So if we could go to the next slide. All right. So this information that I gathered is information that is available to the public. It's resources that we use that come from, trusted sources. So this is from the National Cancer Institute, NCI. I've also gathered information from CDC, American Cancer Society. So things that, like, first of all, I'm not a doctor. Sorry to disappoint everybody if you came expecting a doctor to be talking about all this stuff, but that's the point, is that you do not necessarily need to be a doctor to understand this stuff. So what I'm going to do is go through it, the information that is out there that is available. Kellen, if you have anything to add, expand, feel free to jump in. But once I get through it, we'll debrief and talk about the conference that you mentioned. If you want to quickly just sort of explain what that was about, if you could, please.
Sure. So I just want to disclose that the work that I will be discussing was done at a previous organization that I worked at called Hopi Cancer Support Services. I'm no longer employed with the Hopi Cancer Support Services, but I do communicate and still work as a collaborator with NACA, Native American Community Action under the Family Health Center as a diabetes health coach. And the event that we were describing is our Men's Night Out event that we've had, that I've had an opportunity to work with during my tenure at the Hopi Cancer Support Services.
Excellent. So I'm hoping that from your experience doing that, we can kind of just talk about, issues that come up, how to get guys talking about this stuff, how to get people to sort of overcome that initial shyness of even, talking about this subject. Because right off the bat, look at these pictures that I'm putting up here.
For sure, yeah. It's very sensitive for males to talk about male organs and male genitalia, but you know, it's one of those things. Once you get over that initial hump, then it actually you're enlightened by some of the responses of people. We'll get into that later, but I'll let you do your presentation here.
All right, sounds good. So yeah, like I said, these are the body parts that we're going to be talking about, that it's important to talk about. And I think just showing the image and getting started is the way to do it. And, you know, I'm sure that this is, if you're presenting it to a classroom or a crowd, this is when the giggles and the whispers will start. But you know, this is available, cancer.gov, that's the National Cancer Institute. So the University of Arizona Cancer Center is funded by the National Cancer Institute. And we are designated by the NCI as a comprehensive cancer center, and doing outreach is part of that designation. So that's all to say that this is a trusted source, is the NCI, and all this stuff is available in Spanish, which I plan to do this presentation in Spanish for the folks that speak Spanish. So prostate cancer is the most common cancer and the second leading cause of cancer death among men in the United States. Of non-skin cancer, I believe, is the one little caveat there. So the prostate gland, this is what we're talking about. Important to know what the prostate even is and where in the body it's located. So the prostate is a gland that surrounds the urethra, and the urethra is the tube where urine flows through. So what we see in the bigger picture is the outline of the whole area that we're talking about, and that little box that's zoomed in, that is the prostate gland that we see right there surrounding that little tube, which is where the pee flows through. So if that little gland gets too large, it can slow and stop the normal flow of urine. So that would be a sign that the prostate gland is being enlarged. So any stoppage of flow in urination or trouble urination could be a sign something's going on with the prostate. And then prostate cancer is usually more prevalent in older men. So if we could go to the next slide, please. So this picture provides a little comparison. There's the normal prostate on the left, and then enlarged on the right. So if you see at the top there, there's the bladder, the urine goes down, but on the right side, if the prostate is too big, it'll kind of close that pipe, and pee will not be able to get out. So with preventing prostate cancer, one of the biggest things to know is to know your own risks, because prostate cancer is rare in men younger than 50. So as you get older, your chance is going to increase. But things that you should know are things like family history, genetics, and the fact that African American men are more likely to get prostate cancer than other men. So something to take into consideration, because if we look at the next slide, these are the recommendations about prostate cancer screening. So if you're thinking about your risks, and the initial point right here, that there is no standard routine or standard screening for prostate cancer. So that means you got to know your risks. And then again, this is the picture that everyone thinks about when talking about prostate cancer. So National Cancer Institute says there's no standard or routine screening for prostate cancer. The screenings that there are the digital rectal exam. So that's the picture right there. That's a doctor examining with a glove, lubricated, goes in the rectum and feels the anus and the prostate, checks for any abnormalities. So you can see going up against the prostate to see what's going on. Now there is a blood test. That's what's called the PSA, prostate specific antigen test. So thing to know about that is it's a level. It can detect the level. That level might indicate cancer, could indicate an infection, something is enlarged, not necessarily precise, but one of the tools that we have. And then the bottom thing says that there's clinical trials for screening underway. So we're trying to improve the way that we can diagnose and find this type of cancer. So, like I said, where does that leave us? Like, what does that mean in terms of screening? When should I get screened? So that's when we turn to the American Cancer Society. If we can go to the next screen. So here we have some good information that we can actually use. Not to say that that other information isn't good, it just kind of leaves you calculating or seeing like, well, where do I stand? So thankfully, we have the American Cancer Society. We can always count on them to give us, straightforward information, and it's right here. So 50 years old, if you're at average age. So average risk, meaning those risks that we discussed before, if you don't have family history, if your risk factors are kind of not elevated. 50 years old is when you should get a screening. If you're higher risk, it's going to be 45. So if you're African American, first degree relative, meaning a father or brother, that was diagnosed at an early age. But then age 40 for men that are at even higher risk. So a first degree relative that had prostate cancer at an early age. Again, this is something that you have to consider all these other factors, your history, talk to your doctor, but it gives you a little bit more to work with, a little bit more certainty in terms of if I'm 45 and African American, then maybe I'm over here on the spectrum of a higher risk. So that's the American Cancer Society, cancer.org, not cancer.gov. Can be a little confusing. And next slide, please. So that was it in terms of my presentation. Maybe let's go to the next slide and then we can come back to this once we're wrapping up. But here's where I wanted to kind of open it up and see, Kellen, what'd you think about that? Is there anything that you would add?
Yeah, it's, again, to reiterate what we were talking about earlier, talking about male genitalia and a lot of the screenings for that regarding male cancer.
Oh, sorry, your screen froze a little bit there.
Cancer screenings, it's really hard to.
Oh, sorry, you're cutting out there, Kellen. 1 second. So I think you're back. If you want to just unmute. Sorry, everybody. Looks like we're having a little technical difficulties, but hopefully Kellen will be able to maybe restart or log off and try logging back on. But it looks like we lost his video. So maybe we can get him back just on audio. Oh, looks like he's back right there.
Okay, can you guys hear me?
Yes, we can hear you perfectly.
Awesome. Sorry, just a little working from home stuff, you know.
No worries. We've all been dealing with it. It
All
happens.
right, so
So if you
just
want to
to
do
add,
just like audio, maybe you can like stop your video and just do audio, and maybe that'll be
yeah,
easier.
we can do that. That will slow or improve the bandwidth.
Maybe
All
you
right.
never know.
Hello?
Perfect. Yes.
Okay. All right, so just to reiterate from what we discussed earlier, talking about male cancer screening is really hard to do because you have to go break through that machismo attitude of that we're tough, we're men, that we're meant to be, you know, not to show vulnerabilities. And
Mm-hmm.
so that's just kind of an attitude that I've come across with a lot of men. And when we would have these group gatherings, a lot of times we would have to do an icebreaker or some type of, um, I guess, a cultural greeting, in a sense, with to kind of break down those barriers and then the attitude. So, for example, one cultural greeting would be just acknowledging myself, that I am Hopi, I am a male, and although I am younger in the age spectrum than most people that I'm talking to that may need this screening, 50 and 50 plus, that we all need to be talking about these things. And so you're right, exactly with the screening, it's very invasive. A lot of times when I do talk to, or when I used to talk to men about digital rectal exams, they would often look at me and say, is that done with a computer? Because oftentimes when we talk about
Yeah.
digital, we think about electronics.
Yeah. Can we go
Eh,
back to that slide, Monica?
And so a digital rectal exam, digits, meaning your fingers,
Or
it's a one index finger. And when you place, when a physician checks for the prostate, they'll use the gloved hand with and then they'll check with one index finger to feel for the prostate in and around that the prostate to see what the size and if there are any nodules on there, um, and oftentimes it's based off of feeling of the physician. So the reason why the United States Preventative Task Force had graded it low is because depending on what physician you go to, they may have more or less sensitivity to feeling the prostate. Again, it all varies. So it may be inconsistent with that diagnosis. Not to say that the diagnosis or the expertise of the physician is not valid. It's just that there's a lot of chances for error. The next one would be the PSA, the prostate specific antigen blood screening. Like you had mentioned before, that varies as well, from day to day, even hour to hour, depending on what type of activity you're doing. The person can raise their PSA levels or they can decrease them. Oftentimes people who are horseback riding, the repetitive pounding on the saddle, those things can also increase PSA activity level. So, they're really unreliable at this point, but it doesn't mean that the person shouldn't get checked. It's very important that a person meeting the risk factors, which is age, 50 plus, or if, in rare instances, if they need to get it earlier from family history, that's another risk factor, then they would have to ask and request it from their physician.
Exactly. And so right away, you can see those issues that we're talking about, right? So first of all, like you mentioned, just the naming, the digital rectal exam, sounds, yeah, like a digital thermometer, sounds like technology, sounds advanced, and like I might not have to deal with anything invasive at all. But it's quite invasive and requires a really good relationship with that physician. In terms of trust, it could be some physician that you just met, but you need to trust that physician to be able to diagnose and make that call, which, like you said, can be subjective or based on their experience or what they are able to, in that moment, be able to achieve in that time allotted. And so then you would think, well, the PSA, that blood test, the prostate specific antigen test, well, that seems like the better option, right? I'll just go in, it'll be a lab, less invasive depending on how you feel about needles, and then we'll have the results right there, and we'll have the numbers, but it's not necessarily that clear.
No, and oftentimes they'll recommend active surveillance because they don't want to keep poking or prodding at the prostate when it could be just an elevated PSA level for that time. So they'll keep checking the PSA levels to see if it's a consistent elevation. But also, that those are the only two options for prostate cancer screening at this time.
Right. And then that's why I mentioned the clinical trials, because on the NCI website, there's information about the genetic tests, but those are under specific circumstances. So there are other things available, but there is a lack of clarity, a lack of a standard recommendation, which I feel is dangerous and could lead to unnecessary deaths if people know, how there's been that back and forth in terms of recommendations.
And earlier you had asked, how do we get beyond these barriers? How do we get into a discussion with men about male screening and, just talking about male genitalia? And the biggest thing is getting men into a comfortable setting where you're not pressing them for an answer, or that you're allowing them to open up to you. And so what we had created, or what was already created back in when I was working with Hopi Cancer Support Services, is that there was an annual men's night out event. And this was just an annual event where almost geared towards like a health fair, where men can come in and listen to different speakers from the health field on a variety of topics, all male related. Now, what changed when we started to kind of look at different things is that I was a part of a project with Dr. Dirk Tahir, and this is through a community Arizona Resilience Grant. And it's this project, we investigate a little bit more about the barriers of what, the Hopi men were feeling when they came to this event. And a lot of times they said that some of the barriers were in a traditional healthcare setting. They weren't able to really open up with their provider as much as they were with the provider outside the healthcare setting at this event. Because we would invite the, some local physicians as well as health experts, and they were able to talk candidly with them as opposed to within a 10 to 15-minute hospital visit. And so knowing that, and then also transportation was a big issue, especially on rural area reservations. And then the other thing was the acceptance of going into a hospital for screening. Though that in itself, it's just like going back to a fitness gym after being stuck in, staying at home for 3 months, and then now deciding to maybe go back to a fitness gym. It's getting ready. That build up is the biggest barrier. So for people who are going in to get a screening, they may not want to know the results. They may not even want to go in for a screening. But they know that it is good for them. So how do we get them in? And then how do we get them to talk about it? Just being real with them. That there's these 2 tests. The risk involved with not getting these tests, that their risks increase for prostate cancer if they do not get any type of screening, just because of just the waiting period. If they do get screened early and it's detected that they do have prostate cancer, then there are options there, a lot of options actually. And one individual that I have met went through this process and was able to see it through, got detected early, was able to get the treatment done, and it was not an invasive treatment. It was a low dosage chemotherapy, which actually didn't cause any hair loss or any types of side effects. So this was stage 1. But people in stage 3 or 4, I've seen recover as well through advanced therapy. So, but the first step is just knowing and getting that this screening done. And oftentimes I tell the guys, it's like a check engine light. We all have vehicles, or we've been in a vehicle where maybe something went on, a light on the dashboard went on, and it's warning you about something. Your options are, do you proceed and take that chance and risk, or do you take it into the garage or wherever and get it checked further and to find out maybe something else? So that's basically the basic concept of that, is that, these are check engine lights of these screening options. And so if it comes back positive, that doesn't mean that you have cancer. It just means that we need to investigate a little bit more into it. And so we're able to then make a better diagnosis with more advanced screening measures. Maybe actually going in and visually seeing that. A physician would then determine if it is cancerous or not. So that's the basic concept with that.
And yeah, I connect with that so much because, a big issue I think is machismo. I, as a Chicano, Latino, Hispanic, it's something that I've encountered, just this, feeling of like, well, we can't talk about that right now because that's showing fear or weakness. But what I found is that I just have to find the right words. you know, because it's all about how you, if you frame it as something that you need to be scared of, then yeah, it becomes this conversation about, well, I don't want to know that I have that, because then who's gonna, you know, do all these things that I need to do for my family? So the way that I've found is to connect it to family, um, especially when talking about something that was, you know, passed on. So if an uncle, a grandfather had prostate cancer, then I can just turn to that dad and say, well, that means that it's there, it's in your family. And so for your children, let's see what's going on there, and let them know that this is something that as a family, we need to take care of, to take care of that family.
Yeah, it really does boil down to family and your connection with being a provider, an innate provider as a male. Not to say that, you know, there are strong female households, but it is sometimes where men are under the impression that they have to be a provider in some ways, and so that in itself, it kind of puts a barrier to, you know, the discussion and opening up when they have to then display their vulnerability, like, oh, I do have cancer in my family. But when you talk about it in such a way where you you ask them, you know, well, do you want to be around for your grandchildren? Do you want to be around for your for their graduation? Or, you know, just started putting it in a context where, you know, you are providing for them by taking care of yourself, by being there. And then that in itself really helps to motivate them. Um, it doesn't work for everybody, obviously, but it you know, if the person is connected in some way to their family, that, you know, they are willing to take that next step to get themselves screened, because they want to know, because they want to take a proactive step for themselves and for their family. And oftentimes they'll do it for their family because, you know, I've talked to guys, plenty of guys, when I was working under this project, that they wouldn't do it for themselves, but if it comes to their family, then okay, sure, yeah, I'll do it for my family, because it was very, very selfless of them, a sacrifice, so to speak.
Yes, absolutely. And that's what we have to remember, is that um, there's sometimes those things that can make us stubborn, or that can make us get in our own way, are because we're not looking at the bigger picture. And sometimes we need to think about it, or have someone ask us about our family, to remember the bigger picture, um, and to see, um, you know, where you fall in that. Could we go to that slide, Monica, with the American Cancer Society recommendations? I think it's that one. Yeah. Just so that we can see again, like, because it's so complicated, you know, once we do start that conversation and get somebody thinking, all right, well, it is a good idea, so when should I do it? Then this becomes a whole nother thing of like, well, it's so complicated that I don't even want to worry about it. And then that conversation stops.
Mhm.
Um, but again, we need to reinforce. And, you know, funnily enough, it's something that I was able to have these conversations when we were talking about breast cancer, you know, last year, which is crazy to think it's already been a year. It was from last October when I was out doing these breast cancer events. But there was, at this one event for the Arizona Bilingual newspaper, there was this great group. They had a booth set up, and they all had Dallas Cowboys t-shirts, and it was a bunch of guys. They were all there to support and wear pink. It was like the Dallas Cowboys, breast cancer survivor, I can't remember the name of the team, but they were all great. I'm not a Dallas Cowboys fan, so I was kind of joking around with them about that. But then we started talking about, breast cancer and the survivors they knew, and how important it is for their family that, all their, family members, the women in the family stay, healthy to be able to, keep the family strong. And the conversation shifted to prostate cancer. We started talking about, how it can be a cultural thing of the provider, not wanting to be the one to be taken care of. And out of that conversation, it just became clear that, there is no invincibility. We all need someone to be able to, take over, tap in, take care of the family business, do whatever needs to be done, because no one is invincible.
Yeah, it's the bigger picture, like you had said earlier, that understanding who relies on you, as a supporter or as a dependent, so it's by taking these measures, these preventative measures, whatever it is, that you're educating yourself about your body, and you're taking a proactive step to prevent a lot of the things that are fairly common with a lot of individuals. Not to say that I'm wishing any cancer on anybody, but it's one of those things that you just have to have that in the back of your head. I'm nearing 40, and so I can see it down at the bottom there, age 40 for men at even higher risk. So and a lot of these cancers are getting lower in age. Take, for example, Chadwick Boseman, actor, with colorectal cancer.
That's right.
So these are things that are unnoticed until maybe it becomes more noticed in the media. But a lot of people do suffer from cancer at an earlier age. So it's always good to start the conversation early with your provider, so that way you can kind of get that relationship going and saying, all right, well, I know that my dad and my grandpa had cancer, so would it be advisable for me to get something earlier if they had it when they were in their 30s? It's just a simple question to your provider.
And the provider too, to reinforce that and have the compassion to make sure that, when we're talking about these cancers that can be found, and there are things that we can do as long as we find them. Unfortunately, I didn't add all of like the actual treatment and the, what to do about it once we find it. But, there are treatment options. And what I wanted the focus to be today is preventing and finding it. But, there are options, and there are things that can be done. And the only way, bigger picture, that we're going to be able to cut into these disparities and make it so that, African Americans do not die at a higher rate of prostate cancer than, the rest of the population. Because I think that's all connected. Like, when are we recommending that people get screened? When are physicians taking that time to have those conversations, and also listening and going to those events like that night out?
Mm-hmm. And just creating that space. I believe that, African American population, created that environment with their men. I've seen other research projects related to that, talking circles, meeting groups, going to support groups. You know, it doesn't have to be just a traditional come to this cancer support group, because even the word cancer, it turns off people from even attending, just because of the, again, the barriers we were talking about. So going to some other support group, male or a veteran support group, and then just kind of sliding in the information about male prostate cancer and what the importance is to get screened. Those types of settings, those type of places, you're able to reach out to people in a non-traditional way, but yet start that conversation in an environment that they're comfortable in.
Right. And raising visibility, raising awareness, which is why it's great that we're doing something like this. So I wanted to, let's see. So yes, the last point I wanted to make on this one was that point about fear again. So when we talk about screening and prevention and finding prostate cancer and the next steps for treatment, fear can be something that can cause someone to not want to find out, not want to know, because you start thinking of all these other things of like, well, who's going to pay the bills and who's going to do all this stuff. But ultimately, you know, whoever you are, if you cannot take care of yourself and you're not healthy, then nobody is going to be able to take care of all those things that you need to take care of your family, of whatever it may be. So that's what it's all about. If we could go to the slide with our upcoming webinars. This is what we have planned for the rest of the month of October, talking about breast cancer all month long. Please tune in. Those are going to be Tuesdays at 11 a.m., except for our morning cat chat. That one's a special, a little bit earlier, 10 a.m. That's with Dr. Cynthia Moranti from the University of Arizona Cancer Center. And then all of these will be on our Twitter live stream. You can also sign up to register for the webinar on Zoom. And if we go to the next slide, our contact information is on there. If you would like any of the information that was included on the slides, I can send that over to you. Any questions that Kellen and I did not cover, please send us emails. The big thing that we want to emphasize are the evaluations. So that QR code, if you scan it with your phone or go to that link, is an evaluation for a red cap. Just thoughts, how we can add to this presentation, what you liked, what you didn't like. The cool thing is that everybody that fills one of those is going to be entered to win a prize. So those are the prizes right there, that cool water bottle, hand sanitizer. Everybody, please follow us on social media. Don't know if there were any questions that came through on social media. Let me check really quick. Does not look like we have any questions coming through on the chat. We just have reminder to do the evaluations. Everybody, please, we would really appreciate it. So Kellen, just wanted to say thank you so much. Once again, the webinar featuring Kellen and Kimberly from NACA that we did earlier this year is on our Twitter. Please check that one out. Kellen, did you want to say a little bit about NACA for those that missed that information?
Yeah, sure. So I work for NACA Family Health Center, which is Native Americans for Community Action, based out of Flagstaff, Arizona. So we're up north here, and we provide more than just healthcare services within the community for American Indians and American Indians and Alaska Natives, but we also provide resources, support services, and behavioral health services out at in the Flagstaff area. So if you're around Flagstaff, look us up at naca.org, or actually, sorry, nacainc.org. And so we're there. We have a bunch of resources going on that are online and available for everybody. That way you can properly social distance during this time. We are accepting some in-person visits at the moment too as well. So thank you for your opportunity. I think we did get a question here.
We did, yes.
Okay, it says, go ahead and read it.
Yeah, it says, can you provide some recommendations how spouses can talk about prostate cancer with their partners?
And that's a great question. Oftentimes it's really hard to be able to communicate with your spouse within the household about their health conditions. And so when you're, talking with a male, oftentimes it is a kind of like a carrot, sticking a carrot in front of the person. For men, oftentimes that may work. It's like, hey, I really appreciate you, and this would really mean the world for me if you were to get this screening, because I know then that that it will benefit us. Those are ways to kind of break that ice. But if that's a little bit too invasive, then just let them know how special and meaningful they are, and that this would be worth it for them. I know when we used to do this project back in Hopi, a lot of the men did talk about their wives nagging them to get screened, and with some results that were positive and some results that were negative, saying that they're always on, I quote, they're always on me for getting these tests done. And but it's all out of love, and it's all out of caring. And so expressing that, conveying that the reason why you ask is because I'm in support of your health. I want you to be healthy. I want you to be here with me, and that you're special to me. That's how important that is to me. And I do my annual screenings for you or for us, and all I ask is that you do the same in return. So it is somewhat difficult topic, but there are ways you can open those discussions.
And it can take different strategies, and it might take all the different ones all at once. It will depend. I think, it depends on the partner. It depends on how they look at this. But my feeling, my approach would always be to not focus it on the individual. Instead of saying you are going to get cancer, focus on how it'll affect the dynamics of the family, the community, the bigger picture, so that they cannot internalize it or self-sacrifice, which is the machismo way, I feel, is to silently endure as opposed to if you reframe it, then they see it as an issue that needs to be done for the family, for the community, for the team. And I see more potential for success that way. I don't know. I don't think that there is a recipe.
No, there isn't. There's a lot of different ways. And what I've seen lately are couples coming in to get their, health screenings done at the same facility together. These are older couples, that I'm seeing more of that support. And so, that could be another way of supporting a loved one. They get their annual screening, and then you go to another provider that does your annual screening.
Yep, and everyone's happy, and they're taking care of business, and everyone's on the same page.
You call it a healthcare date.
Yeah. Go out for lunch afterwards, make a whole day out of it. That's great. But yeah, I think the importance is to talk about it and figure out which approach is going to work best, and to raise awareness, and hopefully we'll start seeing, football players, also having the prostate cancer awareness month like they do for the breast cancer awareness month next month. And, for the sake of just getting these conversations going, getting it visibility out there.
Awesome.
And improve enrollment in these clinical trials so that we can get some very precise diagnostic tools that can be less invasive.
For sure. Yes, definitely.
All right. So I think that those are all the questions for us, Kellen. I want to thank you so much for the information, the stories that you shared with us, and for the great work that you guys are doing up there in NACA.
Awesome. Thank you very much, Octavio, and the rest of the UA crew. You guys are doing a great job down there. And hopefully we can send some cool weather down your way fairly soon.
Yes, we would appreciate that. Absolutely. And just let me read this comment here from Luis Alan Rodriguez, from the University of Arizona Research Group, Nosotros comprometidos a su salud. Thank you for such a great amount of information on prostate cancer. Every single piece of the data presented today will help us assist with the underserved Tucson Hispanic people and community. We thank you once again for your time today. Thank you so much, Luis.
Thank you
for joining us. Thank you, Kellen. We'll see you guys on next Tuesday at 11 a.m. Thank you so much.
Okay, bye.
Bye, and do your evaluations, everybody. Win a prize. Have a great day, everyone.